Welcome to AETCM, the emergency medicine channel. Today let us discuss about anemia and its some major evaluation points. I cannot tell the full details of anemia evaluation here because it's a very vast topic. You know that from bone marrow you can have so many different types of cells. From that erythrocytes are produced, leukocytes are produced. Leukocytes, there are two important types, granulocyte and agranulocyte. Then megakaryocytes are produced, that forms into platelets. If the production of any of these cells are coming down, we can call it as anemia for erythrocyte reduction, neutropenia for leukocyte reduction, or leukopenia, thrombocytopenia for reduction in the platelets. Now, anemia is defined as a state in which the level of hemoglobin in the blood is below the normal range of appropriate for age, sex, altitude. So, according to the age, there are different criteria to define anemia. According to the sex, you have different criteria for defining the anemia. And altitude also very important, because very high altitude you need to have more RBCs to circulate the oxygen. There you may require slightly higher range of hemoglobin. If you have slightly low itself, patient can become anemic. Iron deficiency is one of the most common cause for anemia all around the world. There are other causes: B12 deficiency, chronic inflammation, parasitic infection, inherited disorders. There are so many other causes also can produce anemia. But when we are seeing patients in emergency or in OPD, we can see that the major cause for anemia is always iron deficiency. Iron deficiency can be due to reduced intake of iron, or it can be increased loss of blood through the GIT or menstrual periods, like that. But there also we are losing blood, and the iron levels in our body is reducing. So that is a major cause. Males, it is defined as the normal range is defined as 13 to 18 gram per deciliter. Female, it is 11.5 to 6.5 gram per deciliter is a normal range. You can see that difference here in male and female. That's why we have previously discussed that it should be appropriate for the age, sex and altitude. So there are a lot of clinical features for anemia. The main clinical feature will be, whenever there is anemia, the oxygen carrying capacity is normal, but the oxygen carrying capacity of the RBC is normal, but oxygen carrying capacity of the whole blood is reduced. That is because the number of RBCs are reduced and the amount of oxygen which is carried by this anemic blood will be reduced. So oxygen, glucose, various other things are carried by the RBCs, so that will be reduced. So patient can have weakness, lethargy, lethargy and dyspnea on exertion, palpitation, headache, paresthesia, anorexia, indigestion, angina, cardiac failure, amenorrhea, all these things. That weakness and lethargy is all due to the reduction in the oxygen supply and glucose supply to the various tissues. But one of the major cause for palpitation, dyspnea, all these things are due to cardiac failure. The problem in anemia is, when the RBCs are reduced, body will try to compensate that volume by increasing the plasma. So the plasma volume will be increased, RBCs are same. So the total amount of volume in the intravascular compartment, body will try to maintain. This is called as compensation. But the number of RBCs in that is reduced. So patient can have increased volume, but there is no actual RBC in that. So that produces volume overload. Ultimately it will lead to cardiac failure, angina, palpitation, like that. So cardiac failure will be a major problem in the in severe anemia. Now on examination you can see pallor, the white color of the skin, conjunctiva, subconjunctival area, mucosal membrane, all these things. Palm mark creases are pale. Whenever the hemoglobin drops less than 7 gram per deciliter, you can see many patients' palm mark creases are pale. Tachycardia, wide pulse pressure. Heart rate will be increased. That is, the body is trying to compensate for the cardiac failure. Wide pulse pressure also very important. The systolic BP will be very high. Diastolic BP may be normal or very low. Elevated JVP, that's a sign of cardiac failure, congestive cardiac failure. Hepatosplenomegaly also can be there. Hyperdynamic apex, that means cardiac the amount of volume in the heart is very high, that's why it is hyperdynamic apex. Cardiomegaly, ejection systolic murmur, this is called as hemic murmur. Whenever anemia is there, that produces some murmur because of this hyperdynamic circulation. Neuropathies can be there, but neuropathies are mainly seen in B12 or folic acid deficiency anemias, but other types of anemia also patient can have some neuropathic pain because the amount of oxygen and glucose getting inside the nerves by these RBCs are reduced. Jaundice can be there, that is also seen in hemolytic anemia. Now, etiological classification, we have to in detail we can see now the blood loss is the major cause, acute or chronic blood loss. Acute blood loss, trauma, postpartum bleeding. Chronic blood loss, mainly GIT blood loss, that is hookworm is a classical example. Some GI ulcers, NSAID induced ulcers, malignancy in the abdomen that can bleed, and excessive menstrual bleed. So whatever it is, the hookworm infestation is the most common cause for anemia worldwide. Now, due to inadequate production of RBC, B12 and folic acid deficiency, iron deficiency also can produce anemia due to deficiency states. Many drugs can produce anemia. Chronic, especially the bone marrow suppressing drugs. Chronic illnesses can produce suppression of bone marrow, infiltration of many tumors or sarcoidosis like that also can produce anemia. Liver failure, renal failure. So renal failure, it is due to low erythropoietin level. Hypothyroidism, marrow infiltration by leukemia, myeloma, carcinomas. Marrow failure, that is aplastic anemia, myelodysplastic syndrome. Due to excessive destruction of RBC, that is hemolysis. Hemolysis can be due to genetical conditions like spherocytosis, elliptocytosis, pyropoikilocytosis, stomatocytosis. These all are membrane problems of RBC. Patient can have defective RBC membrane that can be killed very fast in the circulation. Hemoglobin defects like sickle cell anemia, there the RBC will be like a sickle that will be producing hemolysis. Thalassemia, defect in the hemoglobin that produces hemolysis. Enzyme defect like G6PD, pyruvate kinase deficiency, that also produces defective RBC and defect increased destruction. Acquired causes PNH, that is paroxysmal nocturnal hematuria, spur cell anemia, immune mediated hemolysis, SLE, rheumatoid arthritis, drug induced hemolysis, infection producing hemolysis like malaria, sepsis. We know that malarial parasite get inside the RBC, grow there or multiply there and rupture the RBCs. Destruction of RBC in large scale leads to hemolytic anemia. Splenomegaly, normally spleen destroys the older RBCs, but when the spleen is enlarged due to any cause, it can destroy RBCs or platelets, so you can get anemia or thrombocytopenia in splenomegaly. Now, based on the morphology, you can see here they are classified into normocytic anemia, microcytic anemia, that is small RBC, macrocytic anemia, that is large RBCs. Based on the causes, inadequate production of RBC, blood loss that we have seen in previous slide, acute, chronic, excessive destruction of RBC. So, whenever we see anemia, we always check for the size of the RBC. We can see whether it's a normocytic normochromic anemia, microcytic hypochromic anemia, or macrocytic or megaloblastic anemia. The causes for all these things are different. That's why we have to see all these things in peripheral smear. Now, whenever we see an anemia case in emergency room, we have to always, emergency room or in ward, we have to always see one of the investigation which is very very important, that is mean corpuscular volume. You can see here MCV normal is 80 to 100, normocytic anemia. Then you have to see the reticulocyte count. Reticulocyte count is less than 2%, then it is called as hypoproliferative. If reticulocyte is more than 2%, it is hyperproliferative. That means destruction is occurring, but bone marrow is producing more and more RBCs, like hemorrhages, hemolytic anemias. Their production of the RBCs are more, that's why reticulocyte production and reticulocyte production index will be very high. Whereas in less than 2%, leukemia, aplastic anemia, pure cell red aplasia, myelodysplastic syndrome, all comes there. If MCV is low, that means it's a small RBC, microcytic anemia. Then we have to see the serum iron and ferritin. If iron and ferritin they are low, then you can see low iron and low serum ferritin. Ferritin is a better marker for iron deficiency than iron, and high iron binding capacity, total iron binding capacity, that is mostly iron deficiency anemia. Then you have to look for the iron deficiency anemia causes, like whether the patient is having any GI blood loss. So we can see whether any stool occult blood is there. Then you can ask the history of menstrual bleed, all these things. Low iron and ferritin with low TIBC, anemia of chronic illness, like you can get in rheumatoid arthritis, SLE, chronic malignancies, tuberculosis, all these things you have to rule out. Then if you go on the opposite side, mean corpuscular volume more than 100, that means a large cell, it is macrocytic anemia. Megaloblasts and segmented neutrophils can be there. Megaloblastic anemia, then mostly it is B12 deficiency anemia or folate deficiency anemia. Most of the time folate deficiency is due to drugs like methotrexate and all, but you can get B12 deficiency, that is very very common. Those who are taking only vegetarian diet without any B12 supplementation, then they can have megaloblastic anemia. Other causes you can see alcohol abuse, myelodysplastic syndrome, liver disease, congenital bone marrow failure, like that. So many other causes are there for megaloblastic anemia. So whenever we see megaloblastic anemia in clinical practice, give 1 or 2 days of B12 injection. That is not very costly. Instead of investigating these cases in detail, you can give 1 or 2 days B12 deficiency. In 48 hours, if there is a significant improvement in the production, then you can see that it is mostly megaloblastic anemia due to B12 deficiency. If required, we can send the B12 levels and folic acid levels. They are very costly investigation, so you can try that also. If they are very low, then the patient may require long-term treatment with B12. Now, depending on the size and RBC size, we have seen all these things in detail previously. Normocytic, microcytic, macrocytic, all are dependent on the MCV levels, and according to the MCV levels, if it is small, it is microcytic, large, high, it is macrocytic, normal, it is normocytic. There are different causes that we have seen in detail in the previous slide. Iron deficiency anemia, what your normal problem will be: hemoglobin is low, MCV is low, MCH, MCHC are also low. Then peripheral smear, it is microcytosis, hypochromia, that color of the RBC is reduced. Serum ferritin is low. Serum ferritin is better marker than serum iron in iron deficiency anemia. Total iron binding capacity is increased. So iron binding capacity is increased because there is no iron in the body. So iron binding capacity is increased. Soluble transferrin receptor, this is not a routinely done investigation, but it is available, it will be increased. Now, once you understand that iron deficiency anemia, you can do some more tests like thyroid function test, stool occult blood test. That is very important, because if stool occult blood is positive, iron deficiency anemia, then it is mostly a GI problem. If it is an elderly individual, we have to rule out malignancy. Young child, we have to rule out hookworm infestation. Some patients with iron deficiency anemia, stool occult blood positive, they may require endoscopy and colonoscopy. Another important investigation in any type of normocytic or microcytic anemia will be serum creatinine, because we know that the erythropoietin is produced in the kidneys. Whenever the erythropoietin levels are low, like in chronic renal failure, it can produce anemia. Many times this low erythropoietin due to renal failure may be associated with iron deficiency. So in a blood picture you get microcytic hypochromic anemia. So in that case, erythropoietin is creatinine is elevated, means it is due to low erythropoietin level with iron deficiency. Now, microcytic anemia, there are different types of anemias can present as microcytic hypochromic anemia. It's iron deficiency anemia, anemia of chronic illness, thalassemia, sideroblastic anemia. Peripheral smear will pick up some of the findings in microcytic anemia. Serum iron, that is very important, low in iron deficiency anemia, but other conditions it may be normal or slightly reduced. Serum ferritin, it is very important marker of iron deficiency anemia. It is not seen in other conditions, but remember, anemia of chronic illness, that's an inflammatory condition. Ferritin is an inflammatory marker. So in that condition, ferritin can be slightly higher. That is very important. Total iron binding capacity is high in iron deficiency anemia, because there is no iron. How much ever iron we give, that can bind to the site. In other conditions, it will be normal. So anemia of chronic illness, iron deficiency anemia, the most important investigation will be soluble transferrin receptor. That will be high in iron deficiency anemia. It will be normal in iron deficiency anemia. It will be normal in anemia of chronic illness, high in iron deficiency anemia. Ferritin is a very good marker. It is low in iron deficiency anemia. It can be normal or high in anemia of chronic illness. So all these investigations will help you to make a proper diagnosis, but history is very important. Once you understand that it is iron deficiency anemia, you have to take whether stool is red color or black color to rule out fresh blood loss or chronic blood loss. Then you have to ask any increased menstrual bleeding. That is also very important. Other lab investigation, they are not very important in routine anemias, but reticulocyte count is very important, because wherever there is an increased destruction of RBC, like B12 deficiency anemia and all, we have already seen in this thing in the 1 or 2 slides back. If the reticulocyte count is not increased, then there is a bone marrow problem. If the reticulocyte count is increased with iron deficiency anemia, then mostly there is a peripheral destruction or peripheral loss, but bone marrow is trying to compensate that. That's why the reticulocyte count is increased or reticulocyte production index is increased. LDH is increased mostly in hemolytic anemia. Haptoglobin, low haptoglobin, moderate to severe hemolysis, but routinely we don't do this investigation, so I am not going to the details of that investigation. Indirect hyperbilirubinemia, that is a very good investigation in hemolysis. Many hemolytic patients, you can see the LDH is elevated, indirect bilirubin is elevated, production index will be increased. So you can make an easy diagnosis of hemolytic anemia. Then you can see what is the cause for hemolytic anemia, whether it is intracorpuscular or extracorpuscular. Intracorpuscular, like defect in the RBCs covering enzymes or in the hemoglobin itself, so that you can investigate. So reticulocyte production index we have already seen, but reticulocyte production index more than 3 or previous slides we have seen it is 2%. Actually it is more than 3, shows a normal bone marrow response to anemia. That means the bone marrow is producing RBCs for a peripheral destruction. But if it is less than 2, then it is good response. The production is not adequate. That means there is a failure in the bone marrow. So more than 2 or 3%, 2 to 3% indicates there is a good response from the bone marrow. So there is a compensation occurring from the bone marrow production. If it is less than 2, then there is no compensation. bone marrow itself is failing. That is very, very important. Now peripheral smear is very important because peripheral smear, I will show after 1 or 2 slides. You can see different types of cells are there in peripheral smear, like in hereditary elliptocytosis, poikilocytosis, all these things. You can see different types of RBCs like elliptocytes or poikilocytes, like the different RBCs, so they can be destroyed in the circulation very fast. Sickle cells can be there sometimes. So peripheral smear is very, very important. Then again, microcytic or macrocytic, hypochromic or normochromic, all these things are also can be picked up by peripheral smear. Coombs test is one important test in hemolytic anemia. Coombs test is positive, means that is a immune mediated hemolysis. If Coombs test is negative and patient is having hemolytic anemia, then it is a non-immune mediated hemolysis. So we can investigate in that way also. If there is a hemolytic anemia, we always do the peripheral smear. We can see lot of abnormal cells. Then we do the fragility test for the covering. We can see hemoglobin electrophoresis. You can see enzyme defects. Then you can see the Coombs test also. If Coombs test is positive, then directly it will become an immune mediated destruction. If Coombs test is negative, then it will become a hemoglobinopathy or something like that. Now other enzymes like G6PD, anti-P, cold agglutinin titers, all these things we can see. Sickle cells, hemoglobin electrophoresis, all these things we can do. Now hemolytic anemia, there are different causes, spherocytosis, elliptocytosis, like that, different causes are there. That all given in this chart. We cannot go to the details of this chart at present. We will be when we discuss each disease, we can discuss all these things. But whenever there is hemolytic anemia, we can pick up the hemolytic anemia initially by a peripheral smear. Peripheral smear is one of the important investigation in hemolytic anemia. Once you understand that peripheral smear is abnormal only, you can go for further investigation. So in peripheral smear, you can see lot of different abnormal cells. You can see whether it is macrocytes, microcytes, spherocytes, stomatocytes, elliptocytes, schistocytes, target cells. These target cells are commonly seen in different types of hemolytic anemia. All these things are in detail given in this chart. Bite cells, sickle cells, teardrop cells, spur cells, Burr cells, hemoglobin C crystals, Raleigh formation, RBC agglutination. So many different types of cells you can see in the peripheral smear. If you have a very good correlation, you can make out the diagnosis there itself, because peripheral smear is a very, very cheap investigation that does not have any big cost. So you can depend on peripheral smear that can easily give you the diagnosis. Now we have discussed about initial basic investigations to make out what is a type of anemia. When we see anemia case, we have to always make out whether it is a microcytic, macrocytic, normocytic. Yeah, in that sense, when you are doing a complete blood count, you can see the MCV. That will be very easy, because when we are sending for a peripheral smear, it is very cheap investigation, but it will take some time. We have to send to lab. The pathologist has to see it and confirm it, and then only we will get a report. Many emergency rooms, they have microscope in the department itself. They can see, if they know to prepare the slide, they can see there itself. Otherwise, when we send a point of care investigation in like hemoglobin, complete blood count, you can see the MCV. That will be very important investigation in emergency room. We can see whether its MCV is normal, high or low. If it is low, then it is mostly microcytic anemia. When it is high, it is mostly macrocytic anemia. When it is normal, it is normally normocytic anemia. Then from there you can pick up, suppose it is microcytic anemia, you ask whether the patient is having any black color stools, any red color stools. Then you can send stool for occult blood. Or you can ask whether the lady is having more menstrual bleeds, All these things are important. And if there is a elevated MCV, we always have to ask whether the patient is vegetarian or non-vegetarian. If he is vegetarian, there is high chance of B12 deficiency. Then we can ask whether the patient is taking any B12 tablets or not. So that all gives you the clue for the diagnosis. Sometimes you can see the patient will be on some drugs or some disease, like chronic disease like rheumatoid arthritis, SLE and all. There the anemia is due to normally due to anemia of chronic illness. If the patient is having any hemolytic anemia, you can see most of them can have some jaundice, splenomegaly and all. Chronic hemolytic anemia can have abdominal pain, gallbladder, cholecystitis or cholelithiasis. Actually, they have cholelithiasis, bilirubin stones can be there. So we have to pick up all these things. Clinical examination is very important. And basically, when the patient is having anemia, we have to see the signs of anemia also, because many patients with anemia can have cardiac failure. So when we see anemia case, severe anemia case, when we are trying to transfuse, like when you are trying to give blood, the cardiac failure part is very important, because patient is already having fluid overloaded situation. When you are transfusing blood to that patient, there is a high chance of acute cardiac failure in that patient, because you are giving another 300 to 500 ml blood into the patient. So before that, you have to give Lasix and remove some amount of fluid. Then only you can give packed cells. So try to give packed cells in chronic anemia. And one more important thing, whenever we are giving 1 pint of packed cells, you can expect only 1 gram per deciliter hemoglobin improvement. So 1 pack improves the hemoglobin by 1 gram %. That's all. So that is also we have to keep in mind. And unnecessarily transfusions should be avoided. Suppose the patient is having 8 or 9 hemoglobin. If the patient is not going for any procedure, if the patient is not having any ischemic heart disease, no need to transfuse the blood, because blood transfusion has got its own risks. So there are so many risks that we can discuss afterwards. So try not to transfuse unnecessarily. Only if there is an emergency, transfuse the blood. And when we are trying to transfuse, try to give packed cells and give Lasix in chronic anemia. Otherwise, patient can go to cardiac failure. Thank you.